Good morning to our colleagues and attendees from the Americas, and a particular thanks to the people from the WFH who have been working hard to prepare for this webinar. Leah and Julia from the back end, Andrina. Good afternoon to our colleagues in Europe, in Africa, and good evening to our attendees from Asia, Asia Pacific, and Australia. This webinar is on advocating for better care for people with von Willebrand disease. Next, please. So during this webinar, the agenda that will take us through includes my introduction and then three important presentations about advocacy and von Willebrand disease, overview of the recent VWD guidelines, and advocating for better care. And then there will be a period of live question and answer, and also some questions that we have received in advance. And then this will end by closing remarks. The period is about 90 minutes, so we hope that we can achieve our goal within this period of time. Next, please. So my name is Magdi Etiabi. I am a hematologist by profession, practicing in Cairo, Egypt, and I have served as a board member on the WFH for 10 years, 2010 to 2020. And it is my pleasure to introduce our eminent speakers who come from different regions of the world and with different experiences. So our first speaker is Mrs. Susie Cooper, and she is a member of the WFH Women and with Inherited Bleeding Disorders Committee. She has von Willebrand type 1 and a son with type 3 VWD. She has been involved with and supported by the Hemophilia Foundation Western Australia since soon after her diagnosis, and she now sits on the committee. Our second eminent speaker is Dr. Jamila Satar. She is a senior consultant hematologist from Malaysia and a member of the WFH VWD and RBD committee. She has a special interest in hemostasis and thrombosis, especially women with bleeding disorders. She is the president of both Malaysian Society of Hematology and the Society of Patient Blood Management. Third, we have Dr. Shahla Sohail. She has been a tireless advocate in achieving treatment for all those living with bleeding disorders in Pakistan. She is a pediatrician by profession and a person with VWD, and has been working very closely with Hemophilia Patient Welfare Society in a voluntary capacity. Dr. Abira Mahin is a final year medical student, the joint secretary of the Hemophilia Foundation Pakistan HFP. She is the president of HFP Rawalpindi Chapter Youth Group, where she has been involved since 2017. She aims to become a hematologist and to play a role in the overall development of the bleeding disorders in Pakistan. Last is Charity Pikiti, is a journalist by profession. She is the chairperson for the Zambian Childhood Cancer Foundation and the Hemophilia Foundation of Zambia. She has been involved in this work for past 9 years, and it has given her much experience in this respect. Next, please. So some tips on this. For the interpretation, please select your language of preference now, by clicking on the left-hand side, the second button from the left-hand side, and then choose the option that you would like to, of the language that you prefer, and please mute your audio. There is an option to mute the original English audio if you would like, for those who will listen to the presentations in English. Next, please. For live interpretation, how can you use it? For those who use Android, please, click the button on the right-hand side of your phone, the three dots, and you will have the language interpretation. Please click it and then choose your language, and please click done in order to be able to listen to the interpretation. Next. For the question and answers, to ask a question, please select question and answer icon and please type your question. If it is in a different language than English, I will receive interpretation to pose it to the relevant, and if it is in Arabic, I will do this since my native language is Arabic. Next, please. So, about this webinar, the von Willebrand disease was first described by Dr. Erik von Willebrand from Finland in the early 20th century. And since then, the knowledge about the disease developed slowly. And we know now that the prevalence of von Willebrand disease is ranging from 1% in the general public as having low von Willebrand factor or some mild symptoms, to those who have symptoms that deserve management and intervention, where we can describe the prevalence as 1 in 10,000. So with this, it's almost similar to hemophilia. And if we look right now in the data from the global survey in 2019, we have close to 200,000 people with about 157,000 patients with hemophilia A, while only we have 80,000 of von Willebrand, which means that we need to do a lot of advocacy work to outreach those patients and try to help them. And this work has been adopted by the WFH over the last 5 or 6 years. And in 2018, in Scotland, the World Congress, we asked for that all the NMOs will participate into an initiative to support the outreach and advocacy for patients with von Willebrand disease. And this webinar is a continuum of this initiative. Next, please. And early this year, and due to joint efforts between the American Society of the Hemophilia, the ISTH, the National Hemophilia Foundation, and the World Federation of Hemophilia, we could successfully publish the 2 guidelines, one on the how to diagnose von Willebrand disease, and the other on the management on von Willebrand disease. And this will be explained thoroughly by Dr. Jamila during her presentation. Next. So what is the importance of the guidelines, or why the guidelines are important? The guidelines are primarily intended to help clinicians make decisions about diagnostic and treatment alternatives, so they are more comfortable with this approach. Other purposes, which are very important, is to inform policy, education, and advocacy, as well as stating future research needs. They may also be used by patients to help them make informed decisions. And these guidelines, we have to note that they are not intended to serve as a standard of care. Clinicians must make decisions on the basis of the clinical presentation of each individual patient, ideally through a shared process that considers the patient's values and preferences with respect to the anticipated outcomes of the chosen option. Decisions may be constrained by realities of a specific clinical setting and local resources, including but not limited to institutional policies, time limitations, or availability of treatments. So these guidelines help to guide or to support the ideal management of patients with VWD in the context of the social values and the local circumstances where the patient is existing. Next. And with this, it is my privilege to ask Susie to talk about the principles of advocacy. Susie, please.
Hello, thank you, Magdi. So I'm going to be talking through some principles of advocacy. I'm a patient and committee member from the Hemophilia Foundation of Western Australia. Okay, so these are my disclosures. So there are none because I'm part of a national organisation. So advocacy overview, I wanted to talk about what is advocacy, why it's important, and what can it achieve. So from a definition perspective, it's defined as public support for or recommendation of a particular cause or policy. There's the definition, and then there's also the experience that is had personally. So I'm going to speak from my perspective as a patient, a parent, and a member of a support organisation. The application of advocacy in practice, for me, that's about being visible. By speaking up and learning, being humble, being curious, being brave, you're able to help. And yes, help on that cause of representation and access to treatment for people with von Willebrand's. So then maybe we'll think about who we advocate for. So firstly, from my perspective, it starts with self-advocacy. So advocacy is also a wider opportunity for the benefit of many, that it can bring wider representation within your local support organisation, ensuring people with von Willebrand's are included, with ways to include women as well. And it can also be about bringing visibility to those who aren't there or able to speak for themselves directly. So in terms of who else we're advocating for or with, the decision makers in the rooms that matter, the people who make funding decisions, they can only answer to recognise needs. They use data, evidence, facts. To get these, someone needs to be doing the research. So advocacy means as a patient group, we are seen because someone is looking at us, hearing from us, and taking into consideration our experiences as well as our needs. Next slide. So then maybe we'll look a bit about how advocacy and von Willebrand's are related. And so advocacy comes in the form of community building, bringing together groups that can contribute their expertise towards improved outcomes. It can be social workers, educators, public health and policy researchers, treatment developers, varied healthcare professionals, medical students, funders. It can also be healthcare professionals talking to other healthcare professionals in their day-to-day practice, acknowledging that it takes comprehensive care to truly deliver improved quality of life. So advocacy was the first way that I understood that I could effect positive change for my son. And I keenly recall being told, you will be the expert in your child's condition. You'll need to be his best advocate. Be your best advocate as well. And this was a matter of acknowledging that the reality of lived experience differs to medical textbooks. And ultimately, as a parent, I'd be delivering the day-to-day management because, you know, who wants to be tethered to a hospital? Initially, in the first years, I felt a lot of pressure to prevent every bleed, to get the best outcome, to push, to agitate. And over the course of years, I learned that advocacy also entails listening as much as speaking. To be a better advocate, I could only learn what he needed and what we could do to help him when I was receptive to new information. So beyond this, I felt the drive to help others access care, to build connections, to empower others. And you can help and build empowerment by hearing, truly listening to what others need and connecting them to resources as well. So that's what advocacy is to me. I've had some opportunities to glimpse the dedication of people working to improve the quality of life with von Willebrands. In all, I'm very impressed with the curiosity, flexibility, and forward thinking that I see. These people, they want to see the stories to go beyond the data. They want to hear from patients. That's how they make sense and get to what matters, how to derive priority amongst it all. Next slide. So advocacy is a bit of a beast. We can talk through some challenges, what's important and what it can achieve. So thinking about the challenges, how many different types are out there, and how do these types affect what you need to look at and what you need to work towards? Are you assuming that factor levels map to bleeding phenotype, the bleeding experience? Because it sure doesn't for everyone. Think about maybe cross-cultural challenges. What do you need to consider locally to achieve effective advocacy? What are the taboos to either respect or break down in your local context? So why is von Willebrand disease advocacy even important? So think about the estimated prevalence that was explained in the beginning of this webinar. Think about that prevalence versus the numbers that are recorded as diagnosed, 1% of the general population. This does not map to the number of people in national registries. This means that there are undiagnosed people who aren't being found, but also that there are diagnosed people that aren't being recorded in registries. Their experience and needs are not being taken into account, and we don't help them. There's the issue of period poverty. Think about the loss in productivity. What is the GDP loss estimate? And remember, these are not just issues in low resource settings. Next slide. So I'm going to join the link with advocacy and von Willebrand disease guidelines. So as discussed before, they were a result of a collaborative effort between the 4 organisations. So patient representatives were actively involved at every stage. And this is something that everyone could be really proud of. We were brought in early, we were valued at every stage, with our opinions specifically and frequently sought. I view the patient involvement as an expression of deep commitment to patient-centred care and improved health outcomes by all the collaborating organisations. The VWD clinical guidelines don't address all treatment situations. There was a limit on the number of questions and variations that could be covered, and we were confined to a very rigorous methodology in question selection. However, we took into account community input. The guidelines make recommendations on interventions, treatments, and if you read through them, you'll see the heavy hitters of impact in patient lives. For example, postpartum hemorrhage, major surgery, dental work. Next slide. So it's important to keep in mind that the guidelines are a technical document. So using them now and considering advocacy will take a little bit of flexible thinking from a patient's perspective. The recommendations might be strong or weak, but that does not mean that the treatment is either suitable or unsuitable. It simply relates to the ability to make a recommendation based on research evidence availability. So the research doesn't say with certainty in scientifically rigorous studies that it will do the most good with the least harm and covers what patients have said they want out of the treatment or the intervention. And I can tell you the endpoint, if you read the guidelines, you'll see that quite a lot of the recommendations are not strong. This all goes to say that we need more research. Next slide. So there will be more work done on educational resources, both for healthcare professionals as well as patients. And this is when the technical documents, they're going to take on a whole new life. There'll be effective tools that we can incorporate into our lives and discussions in our communities and our advocacy work. The guidelines as they are, they're an important tool towards advocacy. They address the invisibility of von Willebrand disease and women with bleeding disorders. So by showing the lack of research and the impacts on ability to provide strong recommendations to healthcare professionals, I believe that the challenge has now been set. This is the challenge to do more research, to take more case studies, to diagnose more people earlier, to hear from patients what matters to them, what are the outcomes they need, or the interventions that are not working for them. Blue sky thinking, perhaps even to develop better treatments. Thank you.
Thank you so much, Susie, for this very thoughtful presentation, which can help guiding the people on how to advocate for VWD. And of course, there will be questions in the question and answer period about some of your points. Now it's my pleasure to introduce Dr. Jamila Satar from Malaysia to give us an overview of the VWD new guidelines. Dr. Jamila, please.
Thank you, Dr. Magdi. Hi, everyone. I hope you all are in the best of health. Dr. Magdi and I are members of the von Willebrand Disease and Rare Bleeding Disorder Committee, which is responsible for recommending and developing activities such as this webinar that we are having for the World Federation of Hemophilia, with the aim to increase awareness and to increase the access of treatment for patients with inherited bleeding disorders. I would like to thank the committee and staff for working very hard to put this webinar together, and to WFH for giving us the opportunity to work together. On behalf of the von Willebrand Disease and Rare Bleeding Disorder Committee and its chair, Dr. Michelle Levin, I would like to extend a very warm welcome to all of you. Thank you for tuning in and making this webinar on advocating for better care for people with von Willebrand disease a success. I will be giving you an overview of the von Willebrand disease management guidelines. As you have heard from Dr. Magdi and Susie, there are two parts to the von Willebrand disease guidelines, that is diagnosis and management. And I will be focusing on the management guidelines. Yeah. Next slide, please. I have no disclosures. Next, please. Okay, this is what the guidelines look like. And the guideline is a joint guideline by the American Society of Hematology, the International Society of Thrombosis and Hemostasis, National Hemophilia Foundation, and the World Federation of Hemophilia. So they selected a multidisciplinary panel, which consists of hematologists, that is pediatrician and adult hematologists, an internist, a dentist, and even a nephrologist, who are all experts in the care of von Willebrand disease, as well as 3 patient representatives, which is unusual. With the previous guidelines, they did not include patient representatives, but here the guideline is very wholesome, and they included the values and feedback from patients. So next slide, please. So the objective of the guidelines is to support patients, clinicians, and other healthcare professionals in their decisions about management of von Willebrand disease. Next, please. So first and foremost, the panel actually formulated specific clinical questions, and then they brainstormed on all the possible outcomes of these questions. And then they rate them with this great approach including the GRADE evidence to decision framework. The GRADE approach stands for grading of recommendations, assessment, development, and evaluation. So they came up with several recommendations and put it to the patient group to comment on them, taking into all the various aspects of the GRADE approach, which are the evidence, acceptability, the cost, the benefits versus harm of treatment, and including the patient's comments and views. They came up with 2 recommendations, either strong or conditional. The strong recommendations are ones that are truly recommended, and the conditionals are a suggestion, yep, to the recommendation. Next slide, please. So they came up with 8 clinical questions and 12 recommendations. And the first recommendation is about long-term prophylaxis. Who should benefit? So they looked at the patients with severe and frequent bleeds. The second recommendation is about desmopressin trial. Which patients should receive a desmopressin trial? And they suggest that those with von Willebrand factor less than 30%, particularly type 1, should get a desmopressin trial. And for 2B, the panel suggests that you should not treat with desmopressin if no trial is done. The third recommendation is antithrombotic therapy for patients with cardiovascular disease. And the panel suggests to treat rather than not to, and to actually assess the bleeding risk throughout the patient's lifetime. The fourth recommendation is about major surgery. So they look at targeting levels. Yeah? So they suggest that we should target both von Willebrand factor level as well as factor 8 levels to above 50% for at least 3 days. Yep. And for 4B, the panel suggested against using just the factor 8 level alone in monitoring treatment. Recommendation 5 is regards to minor surgery, and they suggest that we need to increase von Willebrand factor levels above 50% with desmopressin or factor with tranexamic acid. And for 5B, for minor mucosal procedures, tranexamic alone is recommended if the bleeding phenotype is mild. Recommendation 6 is with regards to heavy menstrual bleeding. And the panel suggested for hormonal therapy or tranexamic acid over desmopressin. And in 6B, tranexamic acid over desmopressin for those who wish to conceive. Recommendation 7 is about neuraxial anesthesia. And the panel suggested targeting von Willebrand factor between 50 to 150% or 0.5 to 1.5 IU per mil. And lastly, the 12th recommendation, which is the 8th clinical question, is about postpartum management. And it suggested that tranexamic acid for 10 to 14 days or longer if blood loss remains heavy. So I will focus and dwell a little more for the first recommendation, that is with long-term prophylaxis, as well as the last recommendation. So for the first recommendation with regards to long-term prophylaxis, the recommendation states that in patients with VWD with a history of severe and frequent bleeds, the guideline panel suggests using long-term prophylaxis rather than no prophylaxis. And as you can see, this is conditional recommendation based on low certainty in the evidence of effects. And from the evidence, there was only one randomized controlled trial comparing prophylaxis versus placebo, and 13 pre-post studies comparing time periods between prophylaxis and no prophylaxis. And the remarks were that they stressed that bleeding symptoms and the need for prophylaxis should be periodically assessed. So the severe bleeding was defined in the randomized control trial as requiring hospital admission, requiring surgical intervention, requiring blood transfusion, and with a hemoglobin fall of more than 2 grams per deciliter, and bleeding in critical sites, such as into muscles, causing iliopsoas hematomas, or into the brain. Yeah. And for frequent bleeding, the definition is 5 or more bleeding episodes in the last 12 months, 3 or more bleeding episodes in the same joint, and 2 or more episodes of unexplained gastrointestinal hemorrhage or due to angiodysplasia. Next slide, please. So prophylaxis is defined as a period of at least 6 months of treatment of von Willebrand factor replacement administered at least once a week. The dose was not mentioned. Here I have a picture of my patient, on the right. She has type 3 severe von Willebrand disease, and she had come in with frequent bleeds into her ankle joints. And hence I decided to start her on prophylaxis. And she could only, she agreed on once a week prophylaxis. So I started her on a dose of 60 IU per kilogram once a week. And she's been doing fine. She's very happy. And she's able to go about with her work, because her work needs her to walk and travel a lot. So she's very happy. She's free from any more joint bleeds. She's also on the levonorgestrel intrauterine system device, or Mirena coil, for her heavy menstrual bleeding, which is perfectly controlled. She's one happy lady. And she is our president of the Malaysian, we call it Club Hemostasis Wanita, or the Women's Hemostasis Club, and she's our president. Next slide, please. So how does this recommendation affect people with von Willebrand disease? Well, from all the studies, it showed that although some were of not statistically significance, but it reduces bleeding episodes, it reduces hematrosis, it reduces heavy menstrual bleeding, reduces hospitalizations, and improves overall quality of life. Here we have all our ladies here who are very active and happy with the treatment they're getting. And of course, it helps towards policy changes, and we can bring this up to our Ministry of Health, to our policy to actually advocate for changes in policy, so that we can have prophylaxis for all those with severe von Willebrand disease. I know it's costly, but I think that's the role of advocacy. So all the ladies out there, let's advocate for better care for all women with von Willebrand disease, especially those with severe disorder which require long-term prophylaxis. Next slide, please. So I will discuss the last recommendation, that is recommendation number 8, the 12th recommendation, actually, clinical question number 8, regarding postpartum management. So the guideline panel suggests the use of tranexamic acid over not using it in women with type 1 von Willebrand disease or low VWF levels. And this may also apply to types 2 and 3 VWD during the postpartum period, And this is conditional recommendation, again, based on low certainty in the evidence of effects. And the good practice statements, suggest that tranexamic acid may be given systematically via the oral or IV route. The oral dose is 25 milligram per kilogram, typically 1,000 to 1,300 milligrams, 3 times per day for 10 to 14 days, or longer if blood loss remains heavy. Next slide, please. So I added this actually. It was not stated in the recommendation. However, it was stated for the recommendation for heavy menstrual bleeding. But I thought that, it is very important to correct any iron deficiency anemia, preferably with IV iron, especially if there is heavy blood loss. I find that we can correct iron deficiency quite quickly with the IV route. As you know, oral iron may not be very suitable, because it causes a lot of gastrointestinal upset. Next slide, please. So how does the recommendation for question number 8 affect people with VWD? So the postpartum management for patients with tranexamic acid reduces the risk of both primary and secondary postpartum hemorrhage. It also reduces the risk of vaginal hematomas. It reduces the need for blood transfusion, and that tranexamic acid is safe for breastfeeding. Next slide, please. So the main takeaways from this guideline, from this management guideline, is that it actually does not differ much from previous ones, except the strengths of evidence were discussed, and the recommendations included patient and family preferences where optimal treatment choice is lacking. So I feel that this guideline is very comprehensive and very wholesome because it got the patient involved. It got their voices heard, and that's very, very important. Next slide, please. What I would like was that there should be more emphasis on the prevention and treatment of iron deficiency anemia prior to conception, antenatally, as well as postpartum, because as you know, anemia is associated with an increased morbidity and mortality, and also it is associated with an increased risk of blood transfusion. So make sure that all the ladies out there, prior to getting pregnant, make sure that all their iron deficiency and iron deficiency anemia is corrected. And make sure throughout pregnancy that this is actually looked into. Next slide, please. So as you heard from Susie Cooper, that we need more research. What this guideline shows that actually there's a paucity of evidence. So we need to look to do more research in prophylaxis versus on demand for patients with severe von Willebrand disease. We need to do prophylaxis for, you need to do research for prophylaxis for heavy menstrual bleeding, its impact on the quality of life, concurrent antifibrinolytic therapy, that is tranexamic acid with prophylaxis, the efficacy of tranexamic acid in the prevention and treatment of postpartum hemorrhage in women with von Willebrand disease. Next slide, please. I will leave you with these recommendations, these 12 recommendations. I would like to thank you for listening in. I hope that I have made my presentation clear, and I would be happy to take any questions during the Q&A session. Thank you very much.
Thank you so much, Dr. Jamila, for this very elaborative yet concise presentation on the VWD and the thorough elaboration on the more important points that we face in our daily practice. And I believe that also is a challenge for patients regarding severe bleeding, the heavy menstrual bleeding, and the postpartum period. And of course, we will have some questions in the question and answer period. Now, it is my pleasure to come back to the advocation and to listen to Dr. Sohail about advocating for better care. Please, Dr. Sohail.
I'm thankful to the organizers of this very important webinar regarding advocating for better care for people with von Willebrand disease. And I am Dr. Shehla Sohail. I'm from Pakistan. I'm a healthcare provider at Lahore HTC. My claim to fame is being the founder member of the Hemophilia Foundation of Pakistan. And I have been working as a full-time volunteer with this organization since the last 2 decades. And this is because the issue is very close to my heart, as I am a person with von Willebrand disease, type 2 and type 3 severe with inhibitors. Hemophilia Foundation of Pakistan will be talking about the organization after I give you my country context. And that is geographically, Pakistan is situated in the South Asia. It spends about 6% of its GDP on healthcare, which might shock the developed world. Healthcare is administered here mainly in the private sector, which accounts for approximately 68 to 70% of all the outpatient visits, including the HFP, which takes about 100% of the bleeding disorder community as its patients, and they all visit HFP and its associated HTCs. Estimated number of persons with bleeding disorders stand at about 20,000 in this country. And out of that, only 3,400 persons with bleeding disorders are registered till date in the National Patient Registry. This is only about 11 to 12%. Now, about the NMO in Pakistan, which is the Hemophilia Foundation, it's a non-for-profit, community-led organization. It is recognized by the World Federation of Hemophilia as the NMO for Pakistan. Considered as a national level network for persons with bleeding disorders in Pakistan. It advocates with the government for safe and quality treatment provision. It also ensures that the treatment, provision, care, and support is provided to the persons with bleeding disorders through its provincial chapters and affiliated HTCs. The liaison with international donors is to secure humanitarian aid for Pakistan is also done by the NMO. And NMO is very active in community engagement and empowerment. If we talk specifically about von Willebrand disease now, the figures from the National Patient Registry as of the 23rd of August, 2021, were 3,400 persons with bleeding disorders enrolled in the National Patient Registry. Out of this, 396 von Willebrand disease patients are registered, which is again 11% of the total that we have. The male and the female gender ratio is that we have, out of the 396 patients, we have got 204 males and 192 females, which is 48 to 51%. The trend analysis, as we see here in the case of von Willebrand disease, is that there is a huge lack of awareness about von Willebrand disease and its genetic ramifications. 11% of the overall registration is what we have in the registry. This is because of the lack of access of diagnostic facilities and then cultural norms and social circumstances which lead to accelerated incidence of von Willebrand disease, that is inter-family marriages and marriages between cousins. Now, increasing the awareness by including carrier mothers and sisters of the patients with bleeding disorders is to strengthen the women power, and reaching out in order to improve care is being undertaken by the NMO and its chapters. Now, talking about the von Willebrand disease advocacy. Now, advocacy is an act or a process that we put in place if we need to push for a cause or an issue. And so advocacy campaign has to be planned before we undertake the advocacy. And in this case, there was in the last couple of years, we have tilted more towards the female population because they seem to have been on behind the screens because of the male dominance in the patients with bleeding disorders. So now we are concentrating on patients with Willebrand disease who are girls. And we also focus on their mothers and sisters. Now, there is a set of targeted actions for treaters as well in this. Recently, a seminar was arranged to impart information, education, counseling, and building support system in the family and influence the community to support this system. And then again, we generate a request for implementation of programs of psychosocial support for females with Willebrand disease who are stigmatized and have to face a lot of marginalization. The other point is to highlight the importance of programs and projects for training of doctors, patients education, and pinpointing the psychosocial issues affecting the female patients of Willebrand disease. The Anemia has worked quite diligently on the Willebrand disease advocacy and has undertaken to find out the challenges that we face when we do this advocacy in case of our patients here. A couple of years ago, we signed a global Willebrand disease call to action and ensure that it is ensure its commitment. This was undertaken in Canada a couple of years ago. Now, according to that, also the clear link between treatment and the well-being of the patients is the top priority, especially in the case of young girls during menarche. Because if you're going to use the hormones or oral contraceptive pills, the parents, the girls should know exactly why are they being given this medication. In addition to this, a safe safe pregnancy and delivery management is ensured, and proper care should be taken of the patient during her postpartum period. The team that looks after these patients should have a good leadership, and there should be the diversity of members in this team. They could be learned gynecologists or hematologists and physicians, pediatricians, and nurses who are working in the labor suites. The patients should be given a reasonable expectations, and message development should be undertaken for future as well because of the issues of arranged marriages and stigma and taboo that these girls have to face. They should be made well aware of the risks of reproductive health in case of being in here in this country where the limited resources are there to pull them out of any dire strait. Real data and refined and verifiable should be put forth when we are talking to these girls. VWD advocacy has got a lot of challenges, but then you have to think about the techniques that you need to overcome them. The challenges are the lack of awareness, which of course is the major issue in this country because of lack of literacy, poverty, lack of access to treatment, the religious and the ethnic issues, and the restrictions that the social and the cultural problems that we have over here. Overcoming techniques are, of course, having awareness seminars in various situations, private counseling, awareness through electronic media, print media, and verbal symposiums in school, colleges, and universities. Then we need to also have an outreach program, which is having seminars in women's colleges and the universities. And these two pictures that I have on this slide are a community worker is having a seminar in a college where she's guiding the girls with infographics. And then there is a other picture where the symposium is being held in a medical college. So as we have quite a lot of presentations already been had for the VWD guidelines, I have to tell you that they are very clear and concise, are suitable to implement in countries with decreased sources. They have a clear relationship between the treating clinicians and recommendations and the values and the requirements of the patients. Treatments outlined with the population that we're dealing with interventions, comparator and out, were clearly workable, especially the one Willebrand disease, in which there are severe and frequent bleeds and patients need to go on prophylaxis. That has been very nicely put forward and very clearly understandable. Then we have one Willebrand disease with cardiovascular disease, especially so coronary heart disease, where interventions have to be undertaken and medications like antiplatelets have to be given. VWD with major surgeries, VWD with minor surgeries, VWD with heavy periods and the management, VWD with PPH. In our HTCs, the guidelines are now in place in the treatment protocols and schedules for the one Willebrand disease patients. Our publications that we have put out for students and women and girls and their relatives for easy learning is these pamphlets that we have on the left side and this infographics, which is on the right side. So thank you very much for your attention. And it was a pleasure being here. Thank you again.
Thank you so much, Dr. Suhail, for this very important presentation on advocating for von Willebrand disease, especially with women problems. Now we will have a presentation from Dr. Abira Mahin discussing the challenges in VWD care in Pakistan. Dr. Abira, please.
Thank you, Mr. Magdi, for the introduction. Hello, everyone. I hope all of you are in the best of your health. I'll be starting off with the introduction. My name is Abira Mahin, and I've completed my MBBS, and I'm working as a doctor in a government hospital. I am also a person with von Willebrand type 3, which is the severe form. And I've been associated with the Hemophilia Foundation Pakistan for the past 4 years. And I've been working as the Joint Secretary for the Hemophilia Foundation Pakistan, which is the NMO for WFH. And talking about the local chapter, I've also been associated with my local chapter, which is the Hemophilia Patients Welfare Society Rawalpindi, and I'm part of the executive board member of the chapter, and I'm also working as the president of youth group of Hemophilia Patients Welfare Society Rawalpindi. And I have a special interest in working with women with bleeding disorders, especially with von Willebrand, since I have it as well. Next, please. I will be talking about the challenges we face from patients' perspective involving brand care in Pakistan. Starting off with the beginning, the first and the foremost challenge that we face is the lack of awareness. Lack of awareness is the patients, the families, the mass population, the doctors, the medical community. Since von Willebrand is not very prevalent, although it is very common, but compared to the other diseases we have in Pakistan, von Willebrand is not prevalent in Pakistan. And due to the lack of awareness, the diagnosis becomes very difficult. Whenever a child is born, the bleeding disorders like deficiency of factor 8, factor 7, factor 9, the hemophilia A, B, C, since these are very common, with the male, they present with bleeding at the time of circumcision and they get diagnosed at an early age. But talking about von Willebrand, it is not very common and not many of people are aware of it. When a girl is born with von Willebrand disease, especially, she gets undiagnosed. In the childhood, the major problems that are faced includes gum bleeds and the nose bleeds, and these gets undiagnosed because most of the people do not have the access to the diagnostic facilities. We do not have like the proper screening center, the coagulation screening centers, or the basic tests available in the government hospitals. These are the specialized tests available and they are very costly. And since most of the people in our country who do not have awareness about it and they lack the diagnostic facilities, so von Willebrand gets undiagnosed and is diagnosed usually when the person or the female hits puberty and faces the challenges including the heavy menstrual bleed, or she gets into postpartum hemorrhage or that. Starting off with my journey, I was diagnosed when I was 45 days old. I had a nosebleed, and I was lucky enough, although my parents were not related in any way, but I was lucky enough that I got diagnosed at a very early age, and then I got the proper treatment. But not many of the people are fortunate enough to get such diagnostic facilities and the start of treatment at such an early age. Moving on, the other challenges that we face depending other than the diagnostic facilities are the lack of access to treatment. Once the von Willebrand disease is diagnosed, it's not very easy for everyone to afford the treatment or to get access to the treatment or the proper treatment, if I am talking about it. For fresh frozen plasmas, cryoprecipitates were the only mode of treatment in the beginning, and we did not have any access to the factor concentrates in Pakistan, and it is a recent advancement that these have been important and that we are using the factor concentrates. So when we talk about using the blood products or the fresh frozen plasmas or the cryoprecipitates for the treatment of von Willebrand disease, then we have to talk about the blood-borne diseases that come with them. Hepatitis B, hepatitis C, and the HIV that are very prevalent in the bleeding disorder community, since the only mode of treatment was these blood products, and we did not have access to the factors or the factor concentrates or the safe treatment. Along with these diagnostic and the lack of treatment access, the other issues that are faced in Pakistan include the psychosocial problems, the stigma related to the disease, since it is taken as a taboo. People, since do not have any awareness about it, they are not very sure how the female, especially talking about the females, how the female will be, whether the female will be able to conceive or whether she'll not be able to conceive, how the pregnancy will go on, what will be the problems, how will the postpartum period will be. So talking about all these problems, there is a stigma or a taboo related to the disease, and the females, especially related to that have these disease, become isolated, and they usually don't get married, and they have such issues. And then we talk about the financial issues, the social and the cultural problems. The access, the factor availability is itself a big issue, and even if you have the availability of factors, affording those factors is not possible for everyone, since not everyone is that well off, and these factors are very expensive in Pakistan. And the social and cultural problems are also associated with von Willebrand care in Pakistan, since the disease itself is not very common and the people are not very much aware of it. So if we talk about the major problem that we have in von Willebrand care in Pakistan is the lack of awareness. Due to lack of awareness, there is lack of diagnostic facilities, lack of access to the treatment, all the psychosocial problems and the social and cultural problems related to the disease. Next, please. Now, talking about overcoming the challenges, I'll be talking about the role of Hemophilia Foundation Pakistan and the respective chapters. Talking about Pakistan, the government has so many issues to deal with, since it is a developing country and we are not very much developed like the West or other countries. So they have other issues to deal with, and bleeding disorders and the von Willebrand disease is not a very big issue, and the government has not been involved in the provision of the diagnostic facilities or the treatment for this. So where we have developed like non-profit organizations, and people and the patients are themselves helping themselves to cope with this problem. In this context, the role of Hemophilia Foundation Pakistan and its respective chapters is very much appreciable. Hemophilia Foundation Pakistan has maintained a patient's national registry, and they have made it possible for the people, and they have made the possible communication, and they have made access to the provision of awareness among the people. And for talking about the awareness, the arrangement of seminars, private counseling, awareness through electronic media, print media, and the verbal symposium in schools and colleges and universities, like they've used every means to create awareness among the masses and among the bleeding disorder community about von Willebrand, especially so that these people with von Willebrand disease can live a better life. Now, talking about women, Hemophilia Foundation Pakistan, along with its respective chapters, have been paying very much attention to the women with von Willebrand disease by providing them with diagnostic facilities and easy access to the safe treatment, so they can become independent and they can become a useful citizen of the society. In this context, they have created a national women's group that includes women with bleeding disorders, especially von Willebrand disease, from all over the world. They have also created local women group in respective chapters. They are working as the support groups. They help each other as well, and they've been working together as a group. Another important thing that Hemophilia Foundation Pakistan, which is a very big achievement, is the development of National Hemophilia Helpline. People who do not have access to treatment centers, or who do not get to use the social media, or who do not get access to the hospitals, we have developed a National Hemophilia Helpline. They can call at any time and then get information about the bleeding disorders, and any help or any queries they have that can be answered. Now, talking about overcoming the challenges, since Hemophilia Foundation Pakistan or any other community or the group of people working for the bleeding disorder community is non-profit organization, and that is at a very small scale. As long as the government is not involved, we cannot get the proper diagnosis of all the people with bleeding disorders in Pakistan. So talking about this, the advocacy with the government is a very important issue that we have to deal in Pakistan, and many advancements have been made in the recent years. We have arranged seminars and symposium. We have arranged seminars providing information about what is advocacy, how are we to advocate with the government, what are the things that we need to advocate, and this has been very helpful, and it's still in the progress. And as soon as we create awareness enough about advocacy with the government, then proper steps can be taken to advocate with the government, and then to start off with the problems, overcoming the challenges that we face in Pakistan. Next, please. Now, what is the importance of von Willebrand advocacy? As I've talked about it earlier, that as long as the government is not involved, it's not easy to provide diagnostic facilities or treatment or anything to the people with bleeding disorders, especially von Willebrand in Pakistan. So when the government will be involved, it will be easy to ensure the availability of diagnostic facilities at government hospitals. It will be easy to access safe treatment and treatment for all. It will be easy for the introduction, for the government to introduce different products so that the different factors are available in the country and people can get access to them. And it will be easy to import the factors from international society, or to import the native factors that come from the WFH. And all of these things will help in ensuring the better care for the von Willebrand disease in Pakistan. It was a pleasure being in this webinar. Thank you for your concentration. Thank you, Dr. Magdi. Over to you.
Thank you very much, Abir, for identifying the challenges in Pakistan regarding the VWD and what the efforts that you are doing to overcome this and building the right advocacy. Now, our last presentation is from Charity Pikiti, talking to us about advocating for better care for people with VWD in Zambia. Please, Charity.
My name is Charity Pikiti, the chairperson for the Hemophilia Foundation of Zambia. So today I'm presenting on advocating for better care for people with von Willebrand disease in Zambia. If we look at the prevalence of von Willebrand disease, which occurs with equal frequency among men and women, affecting up to 1% of the general population, the Zambian population is about 16 million people. So we have an estimate of about 160,000 people living with von Willebrand disease in Zambia. And our current register only shows that we have 5 people living with von Willebrand disease. There isn't much knowledge on von Willebrand disease in Zambia. We have so many women dying from maternal death due to excessive bleeding. It's a matter of concern, and the government has been talking about it together with the media we've joined hands such that we have actually started presenting on the issue of the possibility of most of these women dying with maternal death, being women that would have been saved if they were diagnosed to be bleeders. How our NMO has worked on Van Willebrand disease. Our partnership with the Ministry of Health has been our strongest pillar. There is a time that we went up north and we actually got to the northern part of Zambia when there was a woman who just died of severe bleeding after giving birth. We actually managed to set up meetings with the highest authorities there in the northern region, and they gave us a go-ahead to follow up on the woman. From our findings, we discovered that woman actually had a son who is actually a hemophilia patient. So this woman that we lost could have been saved because she's coming from a family of bleeders. And there is a possibility this woman might have died because of the bleeding disorder, a possibility of Van Willebrand disease, which we can't rule out. And then our partnership with the media is something that is our pride, because we are using the media for radio adverts in local languages on Van Willebrand disease. And then also the community, the impact is there because we are speaking in their languages. So they are able to get the early signs and symptoms of Van Willebrand disease. So the media also is something that we have worked on. Thanks to the WFH development grant, we have managed to get to the 5 provinces. So right now, like from September, we have adverts running on Van Willebrand disease and other bleeding disorders that we have done. We are very happy because of the partnership that we have just entered with the Midwives Association of Zambia. These are people that are found everywhere, even in the remotest part of Zambia. They are eager to work with us, and we believe this is going to be to create a great impact on the bleeding disorders community. The fact that we have started the advocacy on Van Willebrand, we are giving ourselves a timeline where we can have a lot of changes for the bleeding disorders community in Zambia, especially to do with Van Willebrand. One thing I've realized, if we are talking of issues to do with women, everybody wants to be involved. We didn't have the numbers because we were not looking for them. But we have already started, thanks to the WFH development grant. We have trainings for midwives and nurses who are the frontliners, and these are the people that are manning the clinics around Zambia. So with these programs that we are doing, we are going to have the confirmation of a lot of numbers affected with Van Willebrand. We are happy with the care system being developed in other regions following the redistribution of health workers. Before we started our advocacy program, it is something that was difficult because the system was not in place where you could find somebody looking after the bleeding disorders community in other regions. But now, the coordination that is there between our organization and then the government, we are working hand in hand such that you'll find that we have links to all the areas now. The only thing that is still remaining is to bridge the gap of trainings. Once we establish the proper system up to the receiving end, I think we are going to have a lot of people that are going to be saved. We are going to save a lot of lives. Van Willebrand disease and other bleeding disorders in Zambia are very much associated with witchcraft. causing myths, stigma, and gender-based violence. You will find that women are not free to come out and say, I have this problem of bleeding. So you'll find that we waste most of the time going to witch doctors, trying to sort help, and like going to the hospital. But with the coming up of the Hemophilia Foundation, you'll find that more women have started coming out also to learn about what Van Willebrand disease is, and then hemophilia. So like I said earlier, maternal deaths are said to have been caused by infidelity of a partner. This myth is very, very strong in our communities. All the women that we have lost due to excessive bleeding, you will find that their husbands are demonized, their husbands are treated so badly because of the same myths that are surrounding the cause of death. So the other thing that we are also doing when we're doing the education and our advocacy programs is education on the possibility of Van Willebrand, which is hereditary. And then the other thing that we are proud to say is that we've done a lot of advocacy and then a lot of presentations to relevant government officials and have built a good relationship over time, such that the Ministry of Health views us as a partner in this important cause. It's evident every time we knock on the doors for the ministry, they are able to open and they'll be able to listen to us because of the great impact that our organization has so far done in the communities and the country at large. We still have challenges with diagnosis due to lack of reagents. We are still advocating for government support in this regard. And then talking about blood-related issues like Van Willebrand disease is a taboo in our society and in our country. There is hope because people are now getting to understand the problem through the awareness programs that we are creating. Regarding the Van Willebrand disease guidelines for 2021, we have not yet started creating advocates based on the 2021 Van Willebrand disease guidelines. When you are not looking for something, you can't find it. And that's one thing we've come to understand and we believe. Now that we know that we have a problem with Van Willebrand disease, and we have started talking about Van Willebrand disease, we are going to have the numbers. With hemophilia, we started with 10, but now we have over 200. And this is a country that has got 10 provinces. It's quite big. But when you look at the programs, the way we are running the hemophilia programs, once we intensify the Van Willebrand disease program, and then also the government to start helping us with the reagents, which we are pushing for, we are going to have a lot of people on our register. Talking of one research that was done by a doctor recently at the University Teaching Hospital, we were able to, it was able to show that there's a lot of women with Van Willebrand disease. She was doing a research on maternal deaths, and then it's there in the public domain. The other thing we can talk about is that not all is lost. We have a wonderful team that will help us incorporate these guidelines into our local document, which is so encouraging. We just recently launched the hemophilia guidelines, where we feel we are going to have the part for the Van Willebrand diseases. So we are going to have time and a chance for the wonderful team to add a chapter or two on Van Willebrand disease, which is going to be quite helpful for all the centers and all the clinics. Thank you very much for listening. I believe we are in this journey together, and we are going to learn more from this webinar, which is going to make a difference in our Zambian community. Thank you very much, and stay blessed.
Thank you so much, Charity, for this very thoughtful presentation about the work done in Zambia for the bleeding disorders community and the starting work on the VWD. Now I would like to ask all the speakers to put on their cameras and microphones in order to start the question and answer period. First, I would like to thank all the speakers. The presentations were very thoughtful, were to the target and respecting the time. We have now close to 13 minutes of question answer discussion, and this will be followed by 5 minutes closing. So we may extend to the 35 time after the hour. So I have personally a question to Susie. You mentioned during your presentation a period poverty. Would you explain to us more what do you mean by this?
Sure. So period poverty is the lack of access to sanitary products, to menstrual hygiene education, to toilets, hand washing facilities, waste management. It's not a unique issue for von Willebrands or women with bleeding disorder. But if you think about the prevalence of menorrhagia, bleeding, longer periods, not having access to those basic essential sanitary provisions means that they will quite often have lower attendance rates in education, but also they're often not able to participate in full-time employment. So it actually magnifies the inequities experienced.
Oh, thank you very much for this elaboration. Now I have an interesting question from Samuel. He's talking about the problems of women with VWD. And he's asking if there is any work that we will include gynecologists to know more about the disease, so that this will facilitate the care for these women. So I will ask Susie again in her capacity as a member of the Women with Bleeding Disorders Committee, and also later Charity to speak about her, experience with the, midwives in Zambia and how this helped to improve the situation. So Susie, please.
Yes, I would say it's crucial to bring gynecologists in. They may be the front line to help with diagnosis, but also very important to help with the management. So things like the insertion of the Mirena device, which is life-changing for a lot of women with their heavy menstrual bleeding. It would be great for gynecologists to always be included in a comprehensive care model, if at all possible. But also midwives. One local example of advocacy we have in Western Australia is we actually speak to midwives in training to get them to consider the range of experiences of women and the range of needs. And it may be that the first time that they come across somebody with an inherited bleeding disorder, they don't necessarily know that this woman has an inherited bleeding disorder, but we talk to the red flags of possible diagnosis as well. So yeah. Midwife and gynecologists, crucially important to include.
Yeah, thank you. Charity, are you able to give us some of your experience on this? How did it work in Zambia?
Thank you, Magdi. I think it's important, like Susie just talked about the involvement of the midwife, because these are people that are there throughout during the process. And then we just started this program, and then we are officially signing an MOU with the association, because we believe it is going to make a very big difference. It's something that has just started in Zambia, so we don't have so much experience. Thank you.
Okay, thank you very much. So we have another question. Probably Dr. Jamila will be the best to answer. He's asking about the safety of using the tranexamic acid with from Willebrand concentrates, and if this leads to any thrombotic events. Dr. Jamila?
Unmute myself. I forgot to unmute
Yeah,
myself.
no problem.
Yeah, okay. Yeah, a good question. Yeah, this is a question regarding the use of tranexamic acid together with a von Willebrand factor concentrates, whether it can increase the risk of thrombosis. Fortunately, I've not encountered, I've used tranexamic acid with von Willebrand factor concentrate, but fortunately, I've not had any thrombosis. But that is the what is lacking. As we have put, as we have said, with regards to the guidelines, that we are lacking of tranexamic acid and von Willebrand factor. But I've used it both, and I don't see any increased risk of thrombosis, fortunately.
Yeah, so there's another question.
Yeah, sorry, I think my internet line is a bit, I think that my bandwidth is a bit low. Can you hear me?
Yes, yes.
Yeah.
Yeah, so the next question is, if a patient developed VTE, venous thromboembolism, how can we manage and in prophylaxis post-surgery? So Dr. Jamila, are you happy to answer this question?
That's a difficult question. So the question is regards to if a patient develops a venous thromboembolism with regards to surgery, is it? Is that regards to surgery or with pregnancy?
How can we manage if he develops venous thromboembolism? So, I mean, in this situation, he may be recommended to use antiplatelets or anticoagulants. And then if this same patient has to undergo a prophylaxis for surgical procedure and post-surgery.
Yeah, I would look at the context of the thrombosis and also the bleeding severity of the patient. Yeah. If the patient had a thrombosis, and I definitely have to treat the thrombosis, and if the patient has a bleeding risk, a high bleeding risk, I would put them also on prophylaxis and start them on. And it's a difficult question. The other thing to consider is doing what do you call it? Interventional thrombolysis, with catheter thrombolysis towards specific to the area of thrombosis. That's the other way. Difficult question. Thank God I've not had any encounter with thrombosis in von Willebrand disease. But what I would do is look at the bleeding risk. If you have enough factors, put them on prophylaxis and treat the thrombosis. Or else I would do directional thrombolysis with a catheter directed thrombolysis.
Yeah, I may have come across several patients, old age, who developed cardiac angina and risk of thromboembolism, and those were recommended to have antiplatelets and had some catheterization procedures for their coronaries. Usually we give them the according to also to the new guidelines, to give the thromboprophylaxis, but we make the patient aware that he might need to have also the von Willebrand concentrates or the factor VIII rich von Willebrand concentrates for prophylaxis from bleeding during the antiplatelet or anticoagulation medications. Also, this one patient had conjoined, or on top of this, a fracture of femur, and he had to have a surgery. So we gave him both prophylaxis by concentrates and also thromboprophylaxis. So, I mean, generally, the guidelines say that we need to give the thromboprophylaxis, whatever it is, but we need also to make the patient aware of the risks of bleeding if he is a severe phenotype. So, Dr. Sohail, your presentation was largely focused on women issues, and it seems that it comes from your heart. So would you tell us the secret of this? You are muted, Dr.
Can you hear me now?
Now it's okay. No.
Okay.
Yeah, okay. No, you're still muted. Still.
Okay.
Yeah, now it's okay.
Right. Dr. Magdi, I've led a long life with one Willebrand's type 3. And being a female in this socio-cultural situation as we have in this country, till the age of 27, I did not know what my bleeding disorder was. And I was told that I had a bleeding disorder, and that was my diagnosis. This was only after my medical graduation that I went for post-graduation to the United Kingdoms. And it was there when I approached the hematology department to ask them as to tell me what I have, that they did the studies on me, the diagnostic workup. And I was told that I had a 1 Willebrand type 3, which was severe. So that was the diagnosis, that I don't want any other female child in my country to go to that age living with an ambiguous type of a diagnosis and not knowing what to do with yourself. So during those first 27 years, every time I had even a tooth bleed, I was giving blood transfusions because I used to get exsanguinated. So that really told me that I nearly had to do something about it. So when I came back to Pakistan, situation did not change. It was still there. So in the last 20 years, we just sort of made a group of friends who were doctors, and they initiated all this diagnostic and treatment facilities. And then I, being a doctor and a patient, was the bridge between the two. And we had quite a lot of people coming in for diagnosis and things, because I used to tell them that please do come over and we need you to be diagnosed. But there was a strange thing that the females were lacking in there. There were no females. All the men used to come for hemophilia A, B, C, whatever, but no females. And it was then that I realized that females are still behind the screens in a male-dominated society, and for a disease to be diagnosed, which is majority of it is male-affected. So it was then that a couple of years ago, that we have started to focus on females now. And we are increasing the number of females as we go along with severe 1 Willebrand type 3. And this is the reason why we have so many type 3s, which is recessively inherited, is because the cousin marriage and the interfamily marriages are very common in this part of the world. And therefore, all the females that we have registered here in the Lahore HTC, 90% of them are children of consanguineous marriages. So a lot of the work, we have to work hard on that. So this is the reason I focused it.
Because we are very short of time right now.
I realize.
Abira, one question that I need one answer. There is a question about the fear of using the plasma and cryoprecipitate in viral transmission. You mentioned this? Do you have the prevalence of these viruses in women who receive plasma in Pakistan?
Well, when we talk about the treatment, I've already told everyone that the mainstay of treatment was blood products in the beginning, that including the flash frozen plasmas and the cryoprecipitates, and for the treatment of anemia, blood transfusions were made very frequently. And since in Pakistan, the blood banks were not very much developed, the proper screening for the viral serologies for hepatitis B, hepatitis C, and HIV, this was not properly done in the beginning. So most of the people getting those transfusions at a very young age acquired these blood-borne diseases, and the percentage of people with bleeding disorders with this blood-borne diseases is very high in Pakistan. Since the screening was not properly done and most of the treatment was done with the blood products. So yeah, this is a very big problem in Pakistan, but this has improved up to a very big extent, since we are now more focused towards the treatment with factor concentrates and the safe treatment for the people with bleeding disorders. So this trend has decreased, but still we have a lot of people with these blood-borne diseases in Pakistan, and it's very difficult to manage them, and it's a very big problem in Pakistan.
Yeah, thank you very much. We actually have a lot of questions, but unfortunately, due to the time limitation, we are not able to answer all the questions. So we would like to go on with the final part of the program. So, I mean, this is a part of a series of actions towards the global from Willebrand disease call to action, promoting adequate care and treatment for people with von Willebrand disease. And each WFH national member organization is invited to sign for this initiative to support VWD and other rare bleeding disorders recognition globally. So far, we have 48 NMOs have already signed. And for more information, please visit the website wfh.org/VWD. Next, please. Also, for questions, you can reach to the WFH or the speakers if you have their links. And also you can consult the websites registered on this slide. Next, please. There are several resources that you can look at, like the guidelines, recommendations for management of VWD, and the recommendation for the diagnosis, and they are available in English, Spanish, French, Arabic, Russian, and simplified Chinese if you access the website highlighted here. Next, please. For the coming events, we have two important events. One which is coming next week, the Global Policy and Access Summit. It is virtual, and we hope that you will registration is open, and we hope that you will join this meeting. And then in November, we will have the WFH 2022 World Congress. It will be in Montreal or virtually for the largest international meeting for the global bleeding disorders community, and the registration will open soon. Yeah, and at the end, I would like to thank you very much. Gracias, merci, shukran, and stay safe. Thank you very much for all of you.